This is it. Hopefully the last, maybe not the last one, because we still got to go over ABGs. But this is going to be the best part here, because again, we're going to talk about some of the problems with pulmonary embolism, and we're going to talk about the distributive processes and how they can interfere with everything. Now, a pulmonary embolism, we usually find this out through history and find out what's going on. But it's usually when there's a blood clot that blocks one of the pulmonary arteries and blocks the blood flow through there. And again, it can lead to decreased pulmonary blood flow and leads to hypoxemia. And again, 1 in 5 cases are actually sudden death cases, so it happens just like that. Again, look for the risk factors here. Pregnant patients, cancer patients. Again, pregnancy, we're talking about an embolism, embryonic fluid embolism, okay? Again, venous pooling, infections, where they non-mobile patients, recent surgeries, okay? Sickle cell anemia, that can cause a problem with these jamming up in the pulmonary arteries, okay? If they've got AFib. So look for all these risk factors. Look for recent surgery is kind of a big one, okay? Is kind of a big one. Look for those things. So an air embolism, fat embolism, amniotic fluid embolism, all of these things, blood clots, these are the sources of those. And again, it is involved in the lung segments that are still ventilated, and therefore you get a ventilation perfusion mismatch, okay? Long and the short, they can breathe, but remember that the oxygen's not on loading, okay? Now again, QPE is sudden in onset and unexplained dyspnea. Usually that's the big thing there, is they can't breathe. I can't catch my breath. I can't breathe. And of course, we as paramedics, we go running in there thinking, we're thinking cardiac. But in our younger patients or patients with those risk factors, keep that pulmonary embolism in the back of your mind, okay? This is especially, they got labor breathing, tachypnea, tachycardia. They got signs of right heart failure. But they're just, again, the story doesn't match with these folks, okay? Usually in 50% of the cases, by the way, they have a deep vein thrombosis, okay? So what's happened is they were immobile. They quit moving around. A thrombus formed in the deep veins of the legs. They traveled up to the heart, went through the heart, got into the pulmonary arteries, okay? You get warm, swollen extremities with thick cord palpated along the medial thigh. And again, so if you're feeling these things, you got, and it extends to the calf, and you got petechiae on the arms or the chest walls, be thinking that deep thing, some sort of pulmonary thrombosis there, okay? So your first priorities are ABCs. Again, it can actually lead to cardiac arrest, okay? And again, the only real way to treat that is to go in and get it, to perform the thrombolectomy. And again, I showed you that in first semester. They can get pretty huge and pretty big, okay? Again, be ready to intratracheally intubate if need be. And again, usually there's a high complication rate and there's a significant amount of mortality, okay? So again, be suspect of it, all right? Spontaneous pneumothorax, blunt or penetrating trauma. We've intubated them and pressing too hard. That would be another reason why. Again, usually male to female, this is proof positive that males do stupid stuff, because that's how the ratio of the male to female patient with a spontaneous pneumo. If they've got the Marfan syndrome, tall, thin structures, history of cigarette smoking, they can usually pop a lung, develop, and again, usually between the ages of 20 to 40, and it usually happens with the COPD or patients that have this happen. All right, so the problem again is it causes a ventilation problem, all right? And it prevents the proper expansion of the lungs, and then they get sharp pleuritic chest and shoulder pain, and they report they can't breathe. It hurts to breathe. So again, they're going to get these diaphoresis pallor-cyanosis is very rarely found, but the tachypnea and the diaphoresis and pallor is, okay? Usually because it only affects maybe 20 to 30% of the lung. And usually what they simply do is most of the time they'll let them ride out and reinflate them. But sometimes they might have to put in a chest tube in order to create the negative suction in order to reinflate the lung. The problem is that when we are ventilating by mask or endotracheal tube, just remember that we run a problem of we can actually cause the tension pneumothorax. We don't want to do that. All right. So again, hyperventilation syndrome. The chest pain, numbness. Numbness is the big one, and they'll club their hands. They have the carpopedal spasms. Again, the cramping in the feet and the hands. They'll be kind of sticking them out. And you're like, here we go. Now, the old school of thought is we can't diagnose hyperventilation system. Well, actually, now with the capnography, yeah, we know exactly what that's going on. Okay, these folks are usually they got a history of fatigue, nervousness. It's not that they can't control themselves. Is once they reach a certain point, is that they can't. Their body doesn't know how to reset itself, and they get into a vicious cycle. They think that they have to breathe faster. Okay, they got a seizure disorder. Again, hyperventilation episodes may precipitate the seizure. They can feel that aura coming on. All right, so reassure them, talk them down. Again, pulmonary embolism and acute MI can exhibit similar symptoms. So that's why we don't put the over there the used to be you would take a paper bag and have them rebreathe their oxygen. What I might do is put them on a non-rebreather mask, maybe start them out at 5 to 6 liters a minute. Make sure that make sure that their SpO2 is still high, and then coach them down at that point. Okay, so you give them just a little bit of oxygen there, but then you slowly talk them down, and with the additional them rebreathing their own carbon dioxide that way, again in a controlled setting where I already have the capno cannula on, where I can see these levels happen, and I assure that I'm not seeing a current myocardial infarction or have a very, very low index of suspicion for the pulmonary embolism. Okay, and again, take a good history before you're doing all this. Okay. Central nervous system dysfunction, it does happen with head trauma, strokes, brain tumors. They start getting weird respiratory patterns. This can also happen with drug ingestion. So again, weird respiratory patterns. Okay, establish, maintain your airway. If the respiratory depression is noted or absent, again, you're going to have to initiate mechanical ventilation. On the stranger ones, the biots, the ataxias, again, controlling the airway, controlling the ventilations might not be a bad idea for those patients. Make sure that you get a saline lock for those guys as well. Again, if you get a spinal cord nerve or respiratory muscles that get damaged, usually the biggest ones are that they just quit breathing on you. Okay. The spinal cord trauma, polio, ALS, which is Lou Gehrig's disease, myasthenia gravis, they lose the muscle control. They actually develop pneumonias pretty easily as well. And ask them about injuries or falls when they have that happen, and if there's been any change there. Okay, because that can be the big one that kind of keys you in on they've lost actually nerve control. Again, and it's not that we can't ventilate them through that. We can provide ventilatory support for these folks and secure their airway. Actually, they do halfway decent once the neurological insult has been fixed. All right, guys, we have reached the end. There's still one more thing I'm going to go through with you guys, so hang tight. And actually, I'm probably going to do that using somebody else's video when we're talking about blood gases. And I think that you need to know how to read blood gases. So we'll probably do that one on the next video. And I'll see you then.